Hi everyone, welcome back to my YouTube channel. Today I'm back with part 2 of calendar year 2023 Medicare Physician Fee Schedule Proposed Rule. Initially, I thought I would be able to cover the content of Medicare Physician Fee Schedule Proposed Rule in 2 videos, but it seems like I will end up creating part 3 to cover the content that pertains to Quality Payment Program and Medicare Shared Savings Program. Let's get started with part 2. Chronic Pain Management Services. CMS is proposing new HCPCS codes and valuation for chronic pain management and treatment services or CPM for calendar year 2023. CMS believes the proposed CPM HCPCS codes would, if finalized, facilitate payment for medically necessary services, prompt more practitioners to welcome Medicare beneficiaries with chronic pain into their practices, and encourage practitioners already treating Medicare beneficiaries who have pain to spend the time to help them manage their condition within a trusting, supportive, and ongoing care partnership. The proposed codes include a bundle of services furnished during a month that CMS believes to be the starting point for holistic chronic pain care, aligned with similar bundled services in Medicare, such as those furnished to people with suspected dementia or substance use disorders. CMS is proposing to include the following elements in the CPM code: diagnosis, assessment and monitoring, administration of a validated pain rating scale or tool, the development, implementation, revision, and maintenance of a person-centered care plan that includes strengths, goals, clinical needs, and desired outcomes, overall treatment management, facilitation and coordination of any necessary behavioral health treatment. On this slide, I am continuing with the elements that have been proposed to be included in Chronic Pain Management Code: medication management, pain and health literacy counseling, any necessary chronic pain-related crisis care, and ongoing communication and coordination between relevant practitioners furnishing care, such as physical and occupational therapy and community-based care as appropriate. Opioid Treatment Programs or OTPs. In order to stabilize the price for methadone for calendar year 2023 and subsequent years, CMS is proposing to revise their methodology for pricing the drug component of the methadone weekly bundle and the add-on code for take-home supplies of methadone. Under this proposal, CMS would base the payment amount for the drug component of HCPCS codes G2067 and G2078 for calendar year 2023 and subsequent years on the payment amount for methadone in calendar year 2021 and update this amount annually to account for inflation using the PPI for pharmaceuticals for human use prescription. Additionally, based on the severity of needs of the patient population diagnosed with opioid use disorder or OUD and receiving services in the OTP setting, CMS is proposing to modify the payment rate for the non-drug component of the bundle payments for episodes of care to base the rate for individual therapy on a crosswalk code describing a 45-minute session rather than the current crosswalk to a code describing a 30-minute session. This would increase overall payments for medication-assisted treatment and other treatments for opioid use disorder or OUD, recognizing the longer therapy sessions that are usually required. CMS is also proposing to allow the OTP intake add-on code to be furnished via two-way audio-video communications technology when billed for the initiation of treatment with buprenorphine, to the extent that the use of audio-video telecommunications technology to initiate treatment with buprenorphine is authorized by the Drug Enforcement Administration or DEA and Substance Abuse and Mental Health Services Administration at the time the service is furnished. CMS is also proposing to permit the use of audio-only communication technology to initiate treatment with buprenorphine in cases where audio-video technology is not available to the beneficiary and all other applicable requirements are met. Additionally, CMS is clarifying that OTPs can bill Medicare for medically reasonable and necessary services furnished via mobile units in accordance with Substance Abuse and Mental Health Services Administration or SAMHSA and DEA guidance. CMS is proposing that locality adjustments for services furnished via mobile units would be applied as if the service were furnished at the physical location of the OTP registered with DEA and certified by Substance Abuse and Mental Health Services Administration. Audiology services. CMS is proposing to allow beneficiaries to have direct access, when appropriate, to an audiologist without a physician referral by creating a new HCPCS code GAUDX for audiologists to use when billing for audiology services they already provide that are defined by other codes. The service or services encompassed by the new HCPCS code would be personally furnished by the audiologist and would allow beneficiaries to receive care for non-acute hearing or assessments unrelated to disequilibrium, hearing aids, or examinations for the purpose of prescribing, fitting, or changing hearing aids. CMS is proposing to permit audiologists to bill for this direct access without a referral once every 12 months. Dental and oral health services. Medicare currently pays for dental services in a limited number of circumstances, such as when that service is an integral part of specific treatment of a beneficiary's primary medical condition. Some examples include reconstruction of the jaw following accidental injury, tooth extractions done in preparation for radiation treatment for cancer involving the jaw, or oral exams preceding kidney transplantation. CMS is proposing to clarify and codify certain aspects of their current Medicare fee-for-service payment policies for dental services. CMS is also proposing and seeking comment on payment for other dental services, such as dental exams and necessary treatments prior to organ transplants, cardiac valve replacements, and valvuloplasty procedures that may be inextricably linked to and substantially related and integral to the clinical success of an otherwise covered medical service. CMS is also requesting comments on other types of clinical scenarios where dental services may be inextricably linked to and substantially related and integral to the clinical success of clinically related services or furnished in connection with other covered medical services, and the potential establishment of a process to review public submissions of recommendations for identifying the circumstances when the policies may apply. Finally, CMS is also seeking comment on potential future payment models for dental and oral health care services and other impacted policies. Skin substitutes. CMS is proposing several changes to their policies for skin substitute products to streamline the coding, billing, and payment rules, and to establish consistency in how they code and pay for these products across various settings. Specifically, CMS is proposing to change the terminology of skin substitutes to wound care management products in order to accurately reflect how clinicians use these products to provide a more consistent and transparent approach to coding for these products, and to treat and pay for these products as incident to supplies under the PFS beginning on January 1st, 2024. Additionally, CMS is soliciting feedback on their key objectives related to key substitute policies, which include ensuring a consistent coding and payment approach for skin substitute products across the physician office and hospital outpatient department setting, ensuring that all skin substitute products are assigned an appropriate HCPCS Level 2 code, including proposal regarding what documentation is necessary to provide CMS for currently marketed and future products, using a uniform benefit category across products within the physician office setting, regardless of whether the product is synthetic or comprised of material, so they can incorporate payment methodologies that are more consistent, and maintaining clarity for interested parties on CMS skin substitutes policies and procedures. Colorectal cancer screening. For calendar year 2023, CMS is proposing 2 updates to expand their Medicare coverage policies for colorectal cancer screening in order to align with recent United States Preventive Services Task Force and Professional Society recommendations. First, CMS is proposing to expand Medicare coverage for certain colorectal cancer screening tests by reducing the minimum age payment limitation to 45 years. Second, CMS is proposing to expand the regulatory definition of colorectal cancer screening test to include a follow-on screening colonoscopy after a Medicare-covered non-invasive stool-based colorectal cancer screening test returns a positive result. Both of these proposals reflect their desire to expand access to quality care and to improve health outcomes for patients through prevention and early detection services as well as through effective treatments. Requiring manufacturers of certain single-dose container or single-use package drugs to provide refunds with respect to discarded amounts. Section 90004 of the Infrastructure Investment and Jobs Act amended Section 1847A of the Act, adding provisions that require manufacturers to provide a refund to CMS for certain discarded amounts from a refundable single-dose container or single-use package drug. The refund amount is the amount of discarded drug that exceeds an applicable percentage, which is required to be at least 10% of total allowed charges for the drug in a given calendar quarter. The proposals to implement Section 90004 of the Infrastructure Act include how discarded amounts of drugs are determined, a definition of which drugs are subject to refunds and exclusions, when and how often CMS will notify manufacturers of refunds, when and how often payment of refunds from manufacturers to CMS is required, refund calculation methodology including applicable percentages, a dispute resolution process, and enforcement provisions. Preventive Vaccine Administration Services. Section 3713 of the Coronavirus Aid, Relief, and Economic Security Act, or CARES Act, amended Section 1861S10A of the Act to add the COVID-19 vaccine and its administration in the same subparagraph as the influenza and pneumococcal vaccines and their administration. In this proposed rule, CMS is proposing refinements to the payment amount for preventive vaccine administration under the Medicare Part B vaccine benefit. CMS is proposing to annually update the payment amount based upon the increase in the MEI and to adjust for the geographic locality based upon the PFS locality where the preventive vaccine is administered using the Geographic Adjustment Factor or GAF. CMS is also proposing to continue the additional payment for at-home COVID-19 vaccinations for calendar year 2023. Additionally, in light of the distinction between a public health emergency declared under Section 319 of the Public Health Services Act or PHS Act and an emergency use authorization or EUA declaration under Section 564 of the Food, Drug, and Cosmetic Act, and the possibility that they will not terminate at precisely the same time, CMS proposes to clarify their policies finalized in the calendar year 2022 PFS final rule regarding the administration of COVID-19 vaccine and monoclonal antibody products to reflect that those policies will continue until the EUA declaration for drugs and biological products is terminated. Rural health clinics and federally qualified health centers, chronic pain management and behavioral health services. CMS is proposing to add the new chronic pain management and behavioral health integration services to the rural health clinics and federally qualified health centers specific general care management HCPCS code G0511 to align with the proposed changes made under the physician fee schedule for calendar year 2023. Since the requirements for the new chronic pain management and behavioral health integration services are similar to the requirements for the general care management services furnished by rural health clinics and federally qualified health centers, the payment rate for HCPCS code G0511 would continue to be the average of the national non-facility PFS payment rates for the rural health clinics and federally qualified health centers care management and general behavioral health codes, CPT codes 99484, 99487, 99490, and 99491, and PCM codes CPT codes 99424 and 99425, and would be updated annually based on the PFS amounts for these codes. Telehealth Services. CMS is proposing to implement the telehealth provisions in the Consolidated Appropriations Act of 2022 via program instruction or other sub-regulatory guidance to ensure a smooth transition after the end of the public health emergency. These policies extend certain flexibilities in place during the public health emergency for 151 days after the public health emergency ends, including allowing payment for rural health clinics and federally qualified health centers for furnishing telehealth services other than mental health visits that can be furnished virtually on a permanent basis under the payment methodology established for the public health emergency, allowing telehealth services to be furnished in any geographic area and in any originating site setting, including the beneficiary's home, and allowing certain services to be furnished via audio-only telecommunication system. The Consolidated Appropriations Act of 2022 also delays the in-person visit requirements for mental health visits furnished by rural health clinics and federally qualified health centers via telecommunications technology until 152 days after the end of the public health emergency. Conforming technical changes to the in-person requirements for mental health visits. CMS is proposing to make conforming regulatory text changes in accordance with Section 304 of the Consolidated Appropriations Act of 2022 to amend paragraph B3 of Title 42 Code of Federal Regulation 405.2463, what constitutes a visit, and paragraph D of 42 Code of Federal Regulation 2469, federally qualified health center supplemental payments, to include the delay of the in-person requirements for mental health visits furnished by rural health clinics and federally qualified health centers through telecommunication technology under Medicare until the 152nd day after the COVID-19 public health emergency ends. Specified provider-based rural health clinic payment limit per visit. Subsequent to the publication of the calendar year 2022 physician fee schedule final rules, which implemented changes to the rural health clinic payment limit as required by the Consolidated Appropriations Act of 2021, interested parties requested clarification regarding the timing of cost reports used to set the rural health clinic payment limit. CMS is proposing to clarify that a 12 consecutive month cost report should be used to establish a specified provider-based rural health clinic's payment limit per visit. CMS believes 12 consecutive months of cost report data accurately reflects the cost of providing rural health clinic services and will establish a more accurate base from which the payment limits will be updated going forward. Clinical Laboratory Fee Schedule, or CLFS. In accordance with Section 4B of the Protecting Medicare and American Farmers from Sequester Cuts Act, CMS is proposing to make certain conforming changes to the data reporting and payment requirements at Title 42 Code of Federal Regulation, Part 414, Subpart G. Specifically, CMS is proposing to revise 414.502 to update the definitions of both the data collection period and data reporting period, specifying that for the data reporting period of January 1st, 2023 through March 31st, 2023, the data collection period is January 1st, 2019 through June 30th, 2019. CMS is also proposing to revise 414.504A1 to indicate that initially data reporting begins January 1st, 2017 and is required every 3 years beginning January 2023. In addition, CMS is proposing to make conforming changes to the requirements for the phase-in of payment deductions to reflect the amendments in Section 4B of Protecting Medicare and American Farmers from Sequester Cuts Act. Specifically, CMS is proposing to revise 414.507D to indicate that for calendar year 2022, payment may not be reduced by more than 0% as compared to the amount established for calendar year 2021, and for calendar years 2023 through 2025, payment may not be reduced by more than 15% as compared to the amount established for the preceding year. Additionally, CMS is proposing to codify and clarify various laboratory specimen collection fee policies in Part 414, Section 523, Paragraph A1. Lastly, in light of questions CMS has received from stakeholders, CMS is proposing to codify in their regulations and make certain modifications and clarifications to the Medicare Clinical Laboratory Fee Schedule or CLFS travel allowance policies. CMS is proposing to add Part 414, Section 523, Paragraph A2, payment for travel allowance to reflect the requirements for the travel allowance for specimen collection. Specifically, in accordance with Section 1833H3B of the Act, CMS is proposing to include in their regulations the following requirements for the travel allowance methodology: general requirements, travel allowance basis, travel allowance amount, and travel allowance amount calculation. Medicare Ground Ambulance Data Collection System. CMS is proposing a series of changes to the Medicare Ground Ambulance Data Collection System. First, CMS is proposing to update their regulations at Part 414, Section 626, Paragraph D1 and E2 to provide the necessary flexibility to specify how ground ambulance organizations should submit the hardship exemption requests and informal review requests, including to their web-based portal once that portal is operational. Second, through review of questions and feedback that CMS received, CMS is proposing further changes and clarifications to the Medicare Ground Ambulance Data Collection Instrument. The changes and clarifications aim to reduce burden on respondents, improve data quality, or both. CMS groups their proposed changes and clarifications into four broad categories: editorial changes for clarity and consistency, updates to reflect the web-based system, clarifications responding to feedback from questions from interested parties and testing, and typos and technical corrections. Lastly, CMS notes that the Consolidated Appropriations Act of 2022 delayed the deadline for MedPAC to submit its report to Congress on the Ground Ambulance Data Collection System study until June 15th, following the date the Secretary transmits data for the first representative sample of ground ambulance organizations. This is it for today. Thank you for joining me. If you found this information useful, please consider subscribing to my channel and leave me a few comments. Hope to see you next time. Bye now.